Hi, good evening, everyone. I'm Sarah here, the host for tonight's talk. This talk is organized by 365 Cancer Prevention Society and OnCall Care Cancer Center. Let me start off by sharing with you the flow for tonight's talk. Our main speaker tonight, Dr. Tay, Senior Consultant Medical Oncology, will be sharing with us on the topic of kidney cancer, what is new and what is next. After Dr. Tay's sharing, we will be having a Q&A session. Please feel free to type your questions in the comments and we'll address them at the end of the talk. We respect your privacy and therefore to ensure the questions you ask are not too personal. Thereafter, I will end off by sharing our upcoming Facebook Live talk. Do help to share and like this Facebook Live and do visit both our social media website by 365 Cancer Prevention Society and OnCall Care Cancer Center. Moving on to our next slide. Do note that all information shared by the speakers and 365 Cancer Prevention Society are for general information only and subjected to changes. Do consult your doctor for personalized medical advice if you have any. Moving on to our next slide. My first colonoscopy campaign is a campaign that is organized by ICON Cancer Center, 365 Cancer Prevention Society, and StarMax Specialty Center. I hope that you can support us by donating to this campaign. You can donate to us by scanning the QR code on the screen. Once again, this campaign is brought to you by 365 Cancer Prevention Society, ICON Cancer Center, and StarMax Specialty Center. And let me share a brief introduction on OnCall Care Cancer Center. OnCall Care Cancer Center is one of the largest and fastest growing private healthcare providers of oncology in Singapore. OnCall Care Vision is becoming a leading center in cancer care in the region, and the mission of adding years and quality of life to all patients through effective knowledge-based, integrated cancer practice and personalized treatment. OnCall Care provides patients with quality care services and treatment administered by qualified medical professionals. The services and treatment offered by OnCall Care includes diagnosis and workup of cancer for adult patients, inpatient and outpatient treatment, cancer screening, and genetic counseling and testing. And as for our speaker tonight, Dr. Tay, he graduated from NUS in 1992 and is awarded the Ministry of Health Manpower Development Program scholarship to train at Dana-Farber Cancer Institute. He also completed the Cancer Medicine and Hematology course at Harvard Medical School. Dr. Tay was the chairperson of Cancer Education for National Cancer Center, and Dr. Tay was also previously the chairperson and management committee member of Children Cancer Foundation. He is an elected member of Singapore Medical Council since 2017. Dr. Tay has been actively involved in clinical and translational research for many years. His clinical interests are in prostate, kidney, testicular, and the bladder cancer. And without further ado, let's welcome Dr. Tay.
Hi Sarah, thank you very much for the very kind introduction of myself and OncoCare Cancer Center and Cancer Center. I'd like to welcome everybody to today's talk and especially on a Saturday evening where you have actually precious time to be spent with your family and your loved ones. But nonetheless, I will assure you that you will not waste your time by listening to something that's very have dynamic changes that has result in a better care and better treatment for patients with kidney cancer. Let me share you my slides. Let me see here. Picture. Okay. All right. Finally, get in. It's been quite we had to go through many rounds of rehearsal just to make sure that I'm in tune with the modern technology. So today we'll be talking about kidney cancer, what's now and what's next. I start off by talking about a patient, a real life patient, a 42 years old man, when in 2016 October, he presented with abdominal pain and weight loss. And he underwent a consultation with a doctor, and a scan was performed, and they found a right kidney mass here. This is the left kidney, and this is the size of the right kidney that is not just enlarged but also deformed. And this is the one that causes the pain. In addition, the scan also showed that at the backbone, we call the vertebral body, there is a destruction of the bone tissue here, and it was encroaching onto the spinal cord. There's a danger that this tumor may encroach onto the spinal cord and cause a paralysis. He underwent a surgical treatment where he removed the tumor of the right kidney and subsequently received a basic therapy called pazopanib to try to control the disease. However, 3 months later, he continued to have pain, and the pain was at the right hip, the back, and the liver. And he had a weight loss of about another 30 kilogram. He came to consult me with a scan that's already performed. And the scan here showed that, this PET scan showed that why he's having pain, because the tumor has involved the right leg, the pelvis, and the kidney as well, over here. Even the sacrum has a tumor that is involved. There's the top of the scalp, and the pelvic bone, where just in front of the hip, the two hips, there's brightness here indicating the tumor is eroded into the bone structure. This is his latest scan in October 2021. There's no evidence of disease in the current PET scan. The skull bone here is clear of cancer. The hip bone here is clear of cancer. The liver is clear of cancer. We did not undergo any surgery, but just medical therapy. And we achieved this result, and this gentleman received this result, possible because of the continuous development in the arena of kidney cancer. Kidney cancer treatment has gone through a lot of changes. Why do we need to talk about kidney cancer? We'll go into the historical perspective. I'll go to the current perspective. And of course, shortly, with just a message on hopes and promises for the future. Why kidney cancer? Kidney cancer constitute about 2 to 3% of all cancers, but the incidence is ever increasing. And the main incidence is actually right now ranked number 8 here. And is increasing because of various reasons. And this is because of the increasing number of patients with hypertension, diabetes, and obesity. You can see that every weight that increase by twofold has a 28% increase in the risk of developing kidney cancer. Men develop kidney cancer more than women, 2:1. It occurs among elderly patients. And smoking, obesity, diabetes, chronic renal failure can increase the risk. It's important that some of these factors, especially the C to F, are preventable. So we need to take care of our health to reduce the incidence of kidney cancer. Now, there's a lot of advancement in kidney cancer. Just to sidetrack, I first gave a lecture I gave a radio talk in 2007 on kidney cancer. And on and off, I still receive messages from my friends or phone calls from my friends saying, hey, you're on radio again. But that was the last time I gave an update on kidney cancer in 2007. Apparently, 93.8 has been replaying the clip on kidney cancer, the advancement of kidney cancer in 2007 now. It is so way back right now that, in fact, I informed 93.8 not to play that clip because it is so outdated. And it's so timely that 365 Cancer Prevention Society invited me to give a talk on kidney cancer. And hopefully 93.8 can listen to this talk and say that there is indeed so much more advancement than the time when I talk about one single drug, sunitinib, in kidney cancer management. Now, the kidney cancer management improvements has always because we understand the kidney cancer better. we understand that um, there are many targets that can be treated, which I will talk about later. But today, I will not talk about the early stage management of early stage cancer because this is more surgical, right? Suffice to say that early stage cancer are cancers that the kidney cancer has not spread beyond the kidney. Beyond the kidney is called advanced kidney cancer or stage 4 kidney cancer. This cancer, kidney cancer, can spread to the lung, to the liver, or anywhere in the body. I've seen a patient with kidney cancer that spread to the internal part of the nose and on the top of the head. Right? So we will be focusing on the management of the late stage kidney cancer or recurrent kidney cancer. Now, the treatment of early stage kidney cancer is actually is to cure and to prevent recurrence because it's localized and amendable with surgery. I just want just to say a few words on surgery. Is usually either the treatment of early stage kidney cancer can be either surgical or radiological procedure. If the tumor is very small enough and they can burn the tumor by using radiological means like using microwave or radiation frequency ablation, that's to preserve the kidney function as well. But if the kidney tumor, if those localized is a bit too big to do so, then they have to do an entire kidney surgery removal. Or if the tumor is at the top, at the side of the kidney, you can do a partial kidney removal and preserving the rest of the kidney function. But even with early stage kidney cancer, there's always a chance of recurrence. It depends on the size of tumor, the grade of tumor. The recurrence risk may vary from person to person. In the most recent study on preventing kidney cancer, right, there is now a treatment called immunotherapy that can reduce the chance of disease coming back. And this is published in 2001 New England Journal of Medicine, where patients undergo immunotherapy, which are described the treatment later, for 1 whole year, versus a group of patients who have undergone surgery but not gone through immunotherapy. The risk of recurrence is reduced by 47%. Now, this is very early studies. The studies reported at 24 months of the closure of study. We will, of course, have to follow up much longer to see whether there is significant improvement in terms of overall survival. Now, let's go to the main meat of the matter, which is the treatment of advanced kidney cancer. Now, historical perspective, in the past, before 2007 or 2004, there has been no effective kidney cancer therapy, no effective treatment for kidney cancer other than immunotherapy. Those are the good old days immunotherapy. Kidney cancer is purported to be not effective, doesn't respond to chemotherapy, hormonotherapy, or radiotherapy. But we do see spontaneous regression of the tumor in patients with advanced disease occasionally. We alluded to a person's strong immunity. But in general, spontaneous regression of the tumor is very uncommon. That's why in the olden days, because of chemotherapy not being effective in kidney cancer therapy, we tried immunotherapy. We got exogenous immunotherapy, where we use interleukin therapy to treat the patient. Although you can see in this graph, the survival probability of those patients who receive this therapy is can cut off to about 20% in the long term. That means 20% of them have survived with advanced kidney cancer. But this therapy was fraught with high incidence of toxicity, and some patients who are not fit may succumb to the treatment. Now, and as a result, the life expectancy was short. But right now, right, because of the increased incidence rate of kidney cancer, there has always been interest in developing the newer therapy. And the newer therapy was developed because of better understanding how the disease was developed. It was known to be a very bloody tumor. And the tumor is very bloody because it's full of blood and blood vessels. And as a result, we continue to understand and understudy why did the tumor develop blood vessels. And it's because of certain loss of protein, loss of certain mutation that result in the blood vessels growth. Pharmaceutical company invest in the trials and develop targeted therapy to target these blood vessels, which retard the growth of this tumor, right? And this is shown in this cartoon. This is the tumor cells, and this is the blood vessel cells. Because of the loss of a certain mutation in kidney cancer associated with kidney cancer, a lot of protein along the cell membrane start to be very active. And this produce signals to the nucleus and allow the nucleus to develop new cells and also to induce the existing blood vessels to grow new blood vessels towards the tumor cells. This allowed the feeding of the tumor with nutrients. At the same time, in the opposite direction, allow the tumor to spread to other organs. With this understanding, pharmaceutical company and researcher developed targeted therapy to target all these active proteins along the cellular membrane. In the past, when we first started treatment, there was only a few targeted therapy called sunitinib, sorafenib, and pazopanib. But in the most recent, there has been increase in the development of better drugs called cabozantinib, include cabozantinib, lenvatinib, which have more targets and targeting them with more potency. The other improvement in the treatment of kidney cancer is the development of immunotherapy, better immunotherapy compared to the interleukin or interferon. Now, we now understand that, there's increasing understanding that most of the time, any cancer cells in the body is due to the escape mechanism. It escape the immune system of the body. The immune system functions in the body to recognize each cell, injured cells, and cancer cells as well. If they can recognize the cancer cell, it will destroy the tumor by attaching itself to the tumor cells and destroy it. But why do cancer cells develop? Why do kidney cancer especially develop in cancer patients? You and me may have cancer cells, but it's because our immune system that is competent to recognize cancer cells that the cancer cells do not manifest in our body. The possibility of kidney cancer development is because our immune cells was unable to recognize the cancer cell. These are immune cells and these are cancer cells. The immune cells may be able to escape the recognition of the immune cells because they may produce a certain protein called PD-L1. PD stands for programmed death ligand, and it attaches itself to the immune cells receptors, causing it not to recognize the cancer cells as the bad cells and allow it to escape and grow as a result. Immunotherapy right now is to able to eradicate this protein from the kidney cancer cells or block the receptor so that the kidney cancer cells protein will not attach to the receptor here. As a result, the immune cells were now able to recognize the cancer cell and destroy it. It's like removing the sunglasses of a policeman, and as a result, the policeman can recognize the cancer cell and thereby catches it and destroy it. But sometimes the immune cells can be recognized by the immune cell can recognize the cancer cell. However, they may not have the strength to destroy it. And this could be due to another mechanism that arises because of the laziness of the immune cells. And this is because of a protein that is produced that is attached itself to the immune cells, telling itself, don't move. You can recognize, but don't move. So the coordination of this pathway allows researcher to develop another drug, another treatment to remove this certain protein so that the immune cells now can be energized and at the same time can recognize cancer cells and destroy it. This double therapy is called double immunotherapy. The anti-PD-L therapy as mentioned earlier, the drugs that are available right now includes pembrolizumab, nivolumab, and the one that's against anti-CTLA-4 is ipilimumab. With the discovery of all this target therapy and immunotherapy since 2007, there have been new advances. As you can see on this slide, in 2007, when I first spoke on the Radio 93.8, it was to actually focus on the improvement of outcome of kidney cancer management with sulitinib, as the first generation targeted therapy against the blood vessels versus standard common immunotherapy. You can see that the survival curve of the sulitinib is above the immunotherapy curve, the old immunotherapy curve of interferon. This indicate there is an improvement in survival at a fixed period of time. And you can see that at the 12 months, there was early reporting, but when at the time of reporting of this study, there was a report of more than 50% improvement in the survival at a period of time. Now reporting about 12 months to 24 months. Beyond that, since newer drugs has been developed, cabozantinib, axitinib, in combination of immunotherapy with targeted therapy of lenvatinib, or lenvatinib with another oral medication called target everolimus, they were compared with sulitinib. It also showed that in 2020 report that the cabozantinib itself was superior to sulitinib, and there was a reduction in disease growth by about 40%. Similar report were found in this combination of immunotherapy with axitinib, another targeted therapy, compared to axitinib alone. And pembrolizumab and nivolumab also showed an improvement about 40 to 60% compared to sulitinib. The double immunotherapy was also superior to sulitinib, but this I don't think I have the slides here. So when we talk about improvement in outcome compared to 2007, there has been a 40% improvement and another 40% improvement followed by another 40% improvement in terms of preventing disease growth when you are faced with advanced disease. I'd like to share with you what is the real life story of another man who is 53 years old. You can see on this PET scan that he has multiple very bright nodules in the lung, both lungs. This is the heart, this is the lung. Very advanced disease. He has what you call a clear cell renal cell carcinoma. This is a standard renal cell carcinoma, the most common type. Sarcomatoid means that it's a grade 4, very aggressive disease. Most of these patients in the past used to die within 1 year, a 1 year period. This is his scan 3 years after the PET scan. The lung nodules have all disappeared. And this is the latest X-ray that was done just this month. Very funny story about him was that he was born in a family of two sons, and the father thought that he was going to die because of the kidney cancer, and he bewailed his business to his second son who do not have the kidney cancer. Now that he's so well, 6 years now, his father has decided to change the will and decided to share the business between the two brothers. I have another patient here. In November 2003, she was 49 years old. Again, presented with a very big left kidney mass. This is the right kidney mass. This is the left kidney mass. You You can see the tumor here on the coronal view. The tumor also invaded to the backbone. All right. She was treated with, at that time and point in time, simple therapy like pazopanib, which is the current that's at the time the standard therapy in 2000 and 2013. The disease was controlled, but soon later, in 2015, there was recurrence. There was recurrence in the uterus. You can see here, the mass here. But in 2015, we started, there were a lot of new drugs available. There was immunotherapy. She consulted, initially when she presented with this disease, recurrent disease, she consulted a gynecologist who told her that you must go for surgery to remove the uterus. At the same time, remove the bladder because the bladder is involved, and to remove the rectum as well. This is called pelvic exenteration. So that she had to carry a pouch to collect the stool, a pouch to pass urine. Fortunately, in fact, I had to plead with her. There's a new therapy in the market, immunotherapy. And I said, just let me try for 2 months and see what's the outcome like. And the rest was history, right? And she's now 58 years old. The pelvis is clean without any surgery. She kept her rectum, she kept her bladder. And although she had again recurrence in her lung, this was in 2001, 2021, March. I tweaked the treatment a little bit more, and the disease is now under control again. So what about the future? I think that for future, of course, we strive to do better for patients. We have won many battles, but we have not won the war. As mentioned earlier, early stage cancer, the aim is to reduce the recurrence, as this now is the standard of care. We'll try to improve and reduce. We'll try to get better therapy to try to further reduce the possibility of recurrence. As for advanced stage of disease, we'll try to improve the outcome of treatment through identifying the right patient to treat with the right drug or the right combination. With more potent combo and the new drugs possible in the pipeline. This morning, I had my clinic I had my morning clinic. Again, I was referred another kidney cancer patient. This is a right kidney tumor over here. It invaded into the renal vein. From the renal vein, it goes to the heart and it goes to the lung. This is continuous work in process. Our fight against kidney cancer never ends because the incidence of kidney cancer is increasing. With that, I'd like to thank you for attending this talk. I'd like to thank the 365 Cancer Prevention Society for organizing this talk, the audience and participants who are listening to this talk today, my staff, Wishan and team for preparing the slides for me, and my patients for the chance to care for them. Back to you, Sarah.
Thank you, Dr. Teh, for insightful sharing. And now we come to our Q&A section. So there's this question coming from Agnes. Her question is, Doctor, I have a thermal mark and have hypodense right renal lower pole nodule of 1.3 cm. Please advise, what should I do?
Sorry, I didn't get you. Can you repeat
the question? Sure. The question is, Doctor, I have thermal mark and have hypodense right renal lower pole nodule 1.3 cm. Please advise, what should I do?
I thought that we are not talking about personal questions, but in general, but this seems to be like a cancer, right? Because hypodensity can be a cyst. So basically, in kidney, not everything you see or mass or hypodensity or a shadow is a tumor. It's important to confirm what is it by consulting your doctor, by doing further testing, like doing a scan, doing other, and sometimes we even need to follow up for a period of time to see whether it's a growth or not. Yeah. So I will not advise him the management because we are not confirmed whether it's cancer or not.
Okay, thank you, Dr. Tay. There's another question from Adeline. Hi, Dr. Tay. First of all, thank you so much for giving this talk. So can you share with us what are the chances of getting a cure or going to remission at the various stages of kidney cancer?
Basically, when we talk about uh, cure rate for kidney cancer patients, really depends on the stage of disease and the grade of disease. We all know about, when we attend a cancer clinic, we always talk about the grade and stage. What do they actually mean? The grade of cancer, it means that how aggressive they are, right? You can have a stage 1 with a low grade, a stage 1 with high grade. Obviously, the high grade cancer, stage 1 has a higher chance of recurrence than stage 1, right? So the size and the spread refers to the stage disease, right? A tumor that is less than 7 cm is stage 1. A tumor that is more than 7 cm is stage 2, right? And whether it involves the vein or not, or the renal vein or not, or the fat tissue around it, will affect the stage. When we stage something is to tell you the potential outlook as a result of treatment. Most of the early stage disease we treat with surgery, and the recurrence rate can be as low as 10% for stage 1 to 60% or 80% for local stage 4 disease. That means they spread to the fat tissue with high grade cancer. That's why for preventive of kidney cancer recurrence, for those who have undergone surgery, we try to identify those with a high risk of recurrence, basically more than 7 cm, a high grade cancer. But for lower grade, it must be bigger than 7 cm, like T3, T4, which is more than 12 cm. Then you may give 1 year of immunotherapy in order to reduce the risk of recurrence by about 30 to 40%. But in terms of stage 4 cancer or recurrence cancer, most of the time, in the past, they used to say that it's not curable. Even with treatment, we can prolong life, but it's not curable. And the cure and how long we prolong the life depends on the character of the cancer. We call it a prognostic group. It can be the very aggressive one. It can be the not so aggressive one. Where the not so aggressive one, when you treat them, they tend to respond well for a longer period of time and they control for a longer period of time before they recur again. They use another therapy and they still can respond. But of a very aggressive one, sometimes they do not respond. Those who do not respond to the first treatment, don't respond to the second treatment, they tend to do badly, and the prognosis outlook is short. Correct. But with the advance of immunotherapy, I will tell you that there is now. I will not now say there's no chance of cure. There is a possibility chance of cure because I've seen with my own eyes, in my own clinic, that what I thought was not curable, the patient is in very prolonged remission. You've seen the few examples, the proof is in the pudding, right? They have advanced cancer, and I thought that they will not survive for 2 to 3 years. But the advance of treatment, every time I treat them when the disease gotten worse, there's new therapy available. Some of these therapies are so good that can induce a complete remission. And then after that, you keep following them years after years. Hey, the disease never come back. I told them that, I think we don't need to scan anymore. We just do an X-ray. Have confidence. It may not come back. So nowadays, it varies from person to person. It's very hard to tell you, but you just need to have your treatment, the right treatment. It's like striking a lottery when when your treatment goes very well, and you do very well, you respond very well. And when you following up, you don't see any disease coming back. That is the most rewarding outcome for me and for the patient.
Thank you, Dr. Tay. And there's a next question coming from Meng Gui. I hope I pronounced your name correctly. So the question is there a screening like colonoscopy to detect early kidney cancer too?
Well, screening for cancer really depends whether you can detect whether the cancer is common enough, whether the screening test is accurate enough, and can find even early stage before they become cancer, not even cancer. But for kidney cancer, unfortunately, there's no method to do so. Yeah. So you just have to listen to your body. In fact, the most early stage cancer are incidental finding. What I mean is that the patient has some other symptoms, and then they go and do say ultrasound or the abdomen for abdominal pain. They found a mass in the kidney. So this abdominal pain is not due to the kidney tumor. It's too small to cause that. So it's an incidental finding. Occasionally, you may have some kidney cancer cancer that produce blood in the urine. But if the tumor is in the periphery of the kidney, they tend not to produce blood in the urine. And by the time they produce blood in the urine, at the time, you're going to be very advanced stage, right? So so you have to listen to the body. Some of the subtle symptoms of kidney cancer could be actually just loss of weight, unrelenting fever. How come I keep getting fever when I don't have any evidence of infection? Yeah. So these are the very subtle signs of kidney cancer. But I don't want you to go back thinking that every fever you must go and screen for kidney cancer. These are far few in between compared to infection or nowadays compared to COVID infection. So to answer your questions, whether there is effective screening for kidney cancer, there isn't. All right, compared to breast cancer and colon cancer.
Thank you, Dr. Tay. Now there's this question coming from Chantel. I hope I pronounced this word correctly. So what is the cause of an angiolymphoma? Will it become cancerous? Will it disappear on its own? And is there any medication to make a 0.8 cm angiomyolipoma disappear?
Okay, angiomyolipoma, the word is very long. It consists of angio, which is a blood, myo means muscle, lipoma means fat. It's a collection of nodules consisting of these three tissues, and it's uncommon. We call it a hamartoma because it is a mixed bag of tissues that's present in the organ that's not supposed to be present in the organ itself. Most of the time, it doesn't cause any problem, and there's no need to treat if it doesn't cause any problem. But occasionally, this type of hamartoma or angiomyolipoma may continue to grow, and anything that is beyond 3 cm, it may cause problem like bleeding and cause a lot of pain as a result of bleeding. But it doesn't turn cancerous, or should I say that it hardly turn cancerous. It's different from what we are talking about today, kidney cancer. It's a different type of topic altogether. Yeah. There are methods to treat, but there's no need to use to treat. Yeah.
Thank you. While waiting for other questions to come in, maybe I can ask a question. Can I ask what are the side effects associated with immunotherapy?
Well, we are talking about modern immunotherapy. Um, the side effect of modern immunotherapy is actually too strong an immune system. We activate the immune system to kick we to attack the cancer cells, but sometimes the immune system gets so strong they start attacking your own body. And the most common side effect or such side effect that we've seen is a bit of diarrhea, where the immune system cells attack the intestine. So we call it colitis, diarrhea due to colitis, right? Colon and itis. Sometimes they get allergy, skin reaction, rashes. You got dermatitis. occasionally it may affect the lung. So lung is what like pneumonia, right? Pneumonitis. But these are far few in between, not so common compared to if you receive chemotherapy for other cancer. Yeah. And it's easy to recognize and easy to treat the side effect by giving steroids to reduce the immune system.
Okay. Maybe I can ask another question. How will kidney cancer treatment affects daily life? Will the patient be able to work full-time, exercise, and perform usual activities?
If we talk about early stage kidney cancer with after surgery, unless the other kidney function is also affected, otherwise you can live a normal life because we only need one kidney to function. All right. But having said that, you have to protect the other kidney. Make sure you don't take too much salt or don't do any exercise that is too violent. That like taekwondo, they may accidentally kick your the other kidney and then you get contusion and affect the kidney function. Other than that, you can live a normal life. In terms of the advanced kidney cancer, with treatment, you can still live a normal life, except that you are inconvenient and need to come to see the doctor on and off, like every month or every 2 months, to receive treatment and for consultation. The target therapy, fortunately, is oral medication. All right. So, and you have to take it every day, right? But you can take every day at home, at the office. There's no need to come to clinic to take. The immunotherapy right now, at the current moment, is the infusion of half an hour at the clinic. You need a blood test, you need followed by consultation and receive treatment for that. By and large, little hindrance to to daily life.
All right. Perhaps I can ask one more question. In terms of like diet-wise, do you have any suggestion how they can eat as well?
Well, I think end of the day, we are talking about prevention of kidney cancer. As mentioned before, obesity. In Singapore, everybody's getting fatter. You need to cut down that by eating better, exercise more. At the same time, also, diabetes can cause obesity, can also induce kidney cancer as well. So we need to prevent diabetes if possible. And for those who have diabetes, control your diabetes better. Also, hypertension. Minister Ong Ye Kung has been talking about uh, fighting a war against salt. And salt is the cause of hypertension. And so it's very important to reduce all these correctable risks. Of course, you cannot correct your sex. My male develop more kidney cancer than female. You can't change that. All right. Neither can you change your aging. So these are uncorrectable risk factors. Yeah.
Okay, thank you, Dr. Day. Maybe I can ask one more question while we see whether there'll be more questions coming in. Could kidney cancer treatment affects a patient's sex life? If so, and how for how long?
Mm, Kidney cancer affects sex life. It all depends. So some patients are so stressed. Of course, the thought of having sex is not is affected. I mean, end of the day, the treatment that they undergo will not affect sex life. Yeah.
Thank you. There's a question from Mei Wu. Will kidney cancer migrate to
Sorry, I just
other
want to interrupt
organs?
that. Those treatment with target therapy can affect congenital abnormality in babies. So it is very important that we must not uh, get a lady or a patient who's a lady pregnant because this drug will cause uh, abnormal development of the limbs and the limbs, including upper limbs and lower limbs in the babies. Is actually a more potent drug than thalidomide. Thalidomide babies are those that has very shortened arm and legs. And thalidomide last time were used to in the past to treat those pregnancy uh, or nausea and vomiting. So now that drug is banned for such purposes. But and this targeted therapy for kidney cancer is a little more potent drug than that. So we must always tell them, you want to have sex, use condom. Do not get anyone pregnant. Yeah.
Thank you. So for Mei Wu, there's a question. Will kidney cancer migrate to other organs later on in life to cause other organs to have cancer?
No, so when we talk about that, I'm assuming that we are talking about where can kidney cancer spread. Yes, kidney cancer can spread. And when they spread, or they can recur, they can usually recur in other organs. They can recur locally in a place where the kidney was that has been removed, or they can spread to other place. Most of the time, it's other place. Like you can see in the examples that I cited, they would like to go to the bone, they like to go to the lung. In fact, as mentioned before, they can go anywhere. Even the ear, I've seen it. Yeah, so it's possible. Yeah, but uh, you got to understand that it's not they develop lung cancer if they spread to the lung. It's the same cell type, cell clone from the kidney. So we don't say that he has lung cancer because of the kidney cancer. We say that he has kidney cancer spread to the lung. And we do not say that he has a bone cancer as a result of the kidney cancer, but it's cancer of the kidney that spread to the bone. They're the same cell type. So that when you use treatment for the spread to the lung, you use a kidney cancer drug and not a lung cancer drug.
Okay, there's this question coming from Angie. Is there any side effect for immunotherapy?
Oh, just now as we mentioned before, there's a lot of potential, a lot of side effects for immunotherapy, but most of them are very controllable, and they're actually quite minor as well. Yeah, any body system can affect by the immune system. Rarely do I see very serious side effect. Some of them are more irritating, more like diarrhea, skin rash, which you can manage with some steroids. I've seen patients that they became diabetic because the immune cells somehow attack the insulin producing cells, they become diabetic. And we are now, by this current patient has stopped the treatment because he's in complete remission. He has had 2 years of immunotherapy, so we stopped the treatment, and hopefully we will see the improvement in diabetes control.
Thank you, Dr. Day. And there's a last question from Susanna. If a breast cancer patient has the cancer spread to their kidneys, how are the treatment done to them?
So it all depends. So this assuming most likely, okay, most likely is a breast cancer that spread to the kidney. So it's a breast cancer cell, not the kidney cancer cell. All right. Although we have seen you can develop kidney cancer as separately while you're having breast cancer. That is very complex. But if it's a breast cancer that spread to the kidney, you treat the disease as for breast cancer using the breast cancer drugs. And that can use chemotherapy, hormonal therapy. Immunotherapy for breast cancer is only for a subset of patient. We call it the triple negative. Yeah.
Thank you, Dr. Day. Our Q&A session will now come to an end. Thank you, Dr. Day, for your insightful sharing tonight. Thank you.
Thank you, everybody. Thank you, Sarah.
And before we end our Facebook Live, we'll appreciate your feedback on today's session. Do help to complete the feedback form by scanning the QR code. And our next talk will be on the topic of all you need to know about colorectal cancer, risk factors, screening tests, and treatment by two speakers. The two speakers are Dr. Patricia Koh and Dr. Chu Ming Ho. It will be on the 6th of April at 8:30 p.m. Do save the date in your calendar, and we hope to see you on the 6th of April. And moving on to our next slide, do visit both our social media website by 365 Cancer Prevention Society and Encore Care Cancer Center. And with that, we'll be ending our Facebook Live talk for tonight. Thank you.